Hi everyone, I'm Holly Johnson, a BSN RN and BSN Entry DNP student of St. Augustine University, taking evidence-based practice course where we are creating an evidence-based practice project applicable to our current nursing practice specialty. I'm an oncology hematology nurse. That's my specialty right now, and I have over 5 years experience within this specialty. I also have 14 years of experience as a nurse. The reason I'm interested in this topic is that I've noticed non-compliance among cancer patients at the infusion clinic where I work, and it has led to serious complications for those patients. Recently, 3 chemotherapy patients of mine ignored essential recommendations, resulting in dehydration and hospitalization. Why, I wondered, were these patients not following the instructions? The non-adherence is often caused by what patients describe as brain fog or chemo brain, which is in technical terms known as cancer-related cognitive impairment. Would better education for these patients be the answer? However, I did give good education using the teach back method. Many patients struggle to remember cancer care instructions due to limited cognitive capacity, which can lead to non-adherence, disease progression, and higher healthcare costs. Cancer-related cognitive impairment affects memory and decision-making. Poor medication adherence in the U.S. results in about 125 deaths annually and contributes to 10% of hospitalizations, costing an estimated $100 billion to $500 billion each year, which is mind-blowing to me. Digital technologies like computerized cognitive training and virtual reality may help improve treatment adherence and patient outcomes by mitigating the cognitive effects. The aim of this PCOT strategy is to discover how this technology can enhance patient well-being and reduce costs. So chemotherapy is an effective cancer treatment. However, along with the condition of cancer and other treatments, it can cause cancer-related cognitive impairment in up to 75% of the patients, leading to memory loss and poor decision-making. Cancer-related cognitive impairment affects memory and attention in chemotherapy patients, reducing adherence to treatment practices like medication and temperature checks, which delay treatment, worsen disease progression, and lead to higher healthcare costs, and increase mortality rates, which can be 8 to 18% higher for those struggling with adherence. So my PCOT question is, in cancer patients over the age of 18 undergoing cancer treatments and experiencing cognitive impairment, does use of digital health applications versus exercise therapy improve memory and decision making within 4 months' time? The population criteria obviously are adults over the age of 18 with cancer diagnosis undergoing the treatment for the cancer diagnosis with cancer-related cognitive impairment, which includes memory lapses and poor decision making. The intervention is digital health applications, which provide cognitive rehabilitation training. The comparison is exercise, which positively affects cognitive function in chemotherapy patients by increasing blood flow to the brain and enhance neurogenesis and neuronal plasticity, and can actually reverse the reduction in glucose metabolism caused by chemotherapy. The outcome will be assessed through the confusion assessment method, which assesses decision-making and memory in cancer patients experiencing cognitive impairment after using the digital health technologies treatment. Research indicates that these technologies can enhance cognitive function by engaging memory-related brain areas and increasing the brain activity in regions critical for decision-making. Based on other successful research, the study will use a 6-week time frame for both the control group, exercise, and the treatment group, digital health technologies. An electronic literature search was conducted across several databases, including Senhall, PubMed, and Google Scholar, for example, using the mesh terms related to digital health technologies and cancer treatments, as seen here in my slide. Only peer-reviewed full-text articles in English published between 2018 and 2024 included, at first, with an additional search on Google Scholar, expanding the time frame to 2010 to 2024 because I wanted to see what had been used in the past. And a few of those I did include. Cognitive training through digital health technologies, CCT and VR, are part of my digital health technologies literature search. Computerized cognitive training, CCT, enhances memory, reasoning, and processing speed by engaging patients in tasks designed to stimulate specific cognitive areas using platforms such as computers, tablets, mobile devices, or virtual reality. Virtual reality training focuses on skills like memory and navigation, allowing for personal training. This multisensory approach can protect against cognitive decline and offers an effective non-drug treatment option for various patient groups, including cancer patients. Studies do show that both exercise plus brain training enhance memory recall, emphasizing the benefits of physical activity for cancer patients. Digital health interventions can enhance glucose metabolism, especially when paired with exercise, which reverses the effects of chemotherapy treatment. Digital health technologies may enhance cognitive rehabilitation in cancer patients with CRCI, according to systematic reviews. However, the evidence is inconclusive regarding their effectiveness compared to exercise programs due to small research samples, as many studies lacked sufficient participant numbers. We just need to have more studies that have the sufficient numbers that are compared to the numbers that were found in the exercise research studies. Caution is advised due to potential bias, emphasizing the need for larger, well-controlled studies before clinical application. The majority of literature reviewed, classified as Johns Hopkins Level A evidence, confirms that digital health technologies positively impact memory and decision-making related to CRCI. But the findings are inconclusive regarding whether or not these technologies provide a better outcome than the control, which is the exercise program, which is standard treatment for CRCI at this time. The evidence-based practice change aims to enhance care for cancer patients with cognitive impairment. Oncologists must approve patients for digital therapy using tools like cognitive computer training and platforms such as CogFit for training memory and decision-making. Computerized cognitive training is an accessible tool that nursing staff can implement at outpatient infusion clinics alongside cancer treatments. This approach could enhance services that benefit other outpatient facilities that focus on cognitive function improvement, such as with my company, Max Health, which is a management company with over 100 offices throughout Florida. Computer-based training can be used to treat cancer-related cognitive impairment in several settings, including in therapy. I thought, we have patients just sitting, receiving chemotherapy. While the various research shows that prior to and after receiving chemotherapy are more optimal for treatment, I'm thinking patients sit there for 5 hours. Why not have a digital technology brain training that they can involve themselves in while they're sitting and receiving chemotherapy? It would be a perfect time. Also, health professionals can use platforms like CogFit to improve cognitive training cancer patient and therapy sessions at home in the healthcare system, which I just described, one place. And then here we have Brain HQ and Rehab.com are examples of these training programs that are available. Consistent with my organization structure, the key stakeholders in the practice include oncologists, neurologists, upper management, official managers, the nursing directors, social workers, patient care coordinators, digital health, AI, IT team coordinators, and oncology patients themselves. The Rogers Diffusion of Innovation model, created by Everett Rogers in 1995, is a framework for managing change in digital health technologies. It outlines 5 stages of innovation adoption: knowledge, persuasion, decision, implementation, and confirmation. Understanding these stages is vital for successfully introducing new technologies in organizations. The model outlines 5 adopter categories: innovators, early adopters, early majority, late majority, and laggards. The innovation decision process includes 5 stages: knowledge, persuasion, decision, implementation, and confirmation. To gain buy-in from superiors such as physicians, providing evidence of the therapy's success through strong presentation research is vital to demonstrate improved patient outcomes. Additionally, offering extra training and support for laggards can help overcome resistance and facilitate adoption. For this project, ideal change agents include a project manager for digital health technology, nurses who assess therapy effectiveness, and participating physicians. Barriers I've identified include digital health therapies struggle with investment and insurance coverage. I can see my upper management being concerned about this because, face it, that's part of what allows us to provide care to patients is the coverage through insurance. So, in addition, physicians may be concerned about limited research and side effects like cybersickness, which has been identified in some of the studies. The confusion assessment method is an effective tool for evaluating delirium in cancer patients, where 62.7% experience this condition. The CAM has greater diagnostic accuracy than the Memorial Delirium Assessment Scale, which has been used in some of the research studies. It is a standardized, evidence-based tool that quickly provides valid numerical results within 5 minutes, enabling prompt identification of delirium by clinicians. This study will use the CAM questionnaire to evaluate both standard treatment groups using exercise therapy and experimental groups incorporating digital health. And here we see what aspects of cognitive function the CAM evaluates. It assesses the presence or absence of delirium through 4 key features: acute onset and fluctuating course, inattention, disorganized thinking, altered level of consciousness. Essentially, it determines if a patient is exhibiting signs of confusion by analyzing these specific cognitive aspects and allows for a numerical classification of the confusion. Results of the CAM questionnaire will be analyzed using a 2-sample t-test, a statistical method for comparing the mean of 2 independent groups. It helps to determine if observed differences between the groups are statistically significant or likely due to chance. The test evaluates the null hypothesis, which states that the mean of the 2 populations are equal. AI algorithms and digital health technologies are used to identify cognitive decline and addresses cancer-related cognitive impairment through personalized brain training. Treatment may be delivered by trained licensed psychiatric staff under a physician's guidance, facilitating cognitive assessments for remote patients. The significance of information technology and healthcare increased following the 2009 HITECH Act, which encouraged health IT adoption. Leading institutions like Memorial Sloan Kettering Cancer Center and Mayo Clinic are integrating these digital solutions to improve recovery outcomes for one example, young brain tumor patients, providing a model for other clinics to observe in a global setting. Improving adherence to supportive care for cancer patients is essential, and digital technologies like computerized cognitive therapy and virtual reality can help address cancer-related cognitive impairment. By effectively treating CRCI, healthcare providers can enhance patient well-being and reduce costs. This review outlines a PCAT strategy to explore how these digital tools can improve patient outcomes. The confusion assessment method is a tool used to assess the effectiveness of digital health technologies and exercise therapy for cancer-related cognitive impairment. Research shows that both treatments are effective individually, but even more so when used together, which was a surprising outcome for me that I didn't realize before. An independent two-sample t-test can analyze the significance between differences in the CAM results between the two treatment groups. Digital health technologies may enhance memory and decision-making in cancer-related cognitive impairment, but they have not yet been proven to be more effective than traditional exercise. Future research with larger populations are needed. If digital health technology rehabilitation therapies are effective, they could be a valuable treatment option in clinical and home settings. The Rogers diffusion of innovation model may facilitate their integration into environments like Max Health, where I work. And then we have the references. I apologize, I went a little bit over time. I can provide references